Well, we currently have a contract with a vendor who does our discharges, and there's some 911 contracts, and the purpose of the RFP was is to establish contracts. However, at this point, the RFP is still in progress because we have not found an overall solution.
So let me try and understand the intent of your question. And is the intent of your question to understand which ambulance providers we currently use to do these to do all these?
Almost every hospital has a contract.
So we have preferred providers and we have preferred rates, which we've developed with almost every ambulance provider in the region. Okay, we do not have service contracts with every one of them, but we have agreed upon rates and rate structures with almost every, if not every, ambulance provider in the community. And we use every ambulance provider that is available to do interfacility transports, to do hospital discharges, to do all of the transportation that we need. We do not do any of that work internally. So we do not do discharges. We very rarely do interfacility transports on our own. Some STEMI from, was it West to Luke's. But all that is done by other commercial vendors, and we use all of the major vendors heavily in all of those areas.
We rely on the trip.
All right, thank you.
Does that answer your
question? All right, thank you. One other question is, do you have a home health care program where you use something like VNS or VNR when you use the nursing services?
We have a variety of home healthcare programs. We do use VNS and other home nursing agencies for kind of basic home care. We also have a house calls program for homebound patients where we send physicians to the home to do the full visits, and then the nursing is provided by VNS, VNS-NY, and then we have a home-based hospital program, so a hospital-to-home program through a CMS Medicare program that does a hospital-level acute stay at home with physicians that we send and nurses that VNS-NY sends.
All right, thank you. John, any other questions?
Again, thank everyone for being here. I'd like to see, I have some people who are listed as perhaps providing testimony in support. Mr. Dr. Davis, I'm not sure, is it Dr. Davis? I don't want to, if he's a hard worker.
Sure.
Mount Sinai is Mr. Davis, Carly Gustafson.
No, we just listed the other.
Are they going to speak?
Mount Sinai witnesses are not going to testify.
They're not going to, okay. That's fine. Ms. Waltman, are you here? Are you going to speak? Yes, please. I would love to have you come. Join us. And please, Ms. Waltman, if you could identify yourself for the record.
Yes, I'm Susan Waldman. I'm Executive Vice President for Legal, Regulatory, and Professional Affairs at the Greater New York Hospital Association. I speak in strong support of the application filed by Mount Sinai to expand its operating area. It's framed as an expansion, but if you think about it, it really is somewhat the same footprint that at least its partner, TransCare, had before it filed for bankruptcy. So it was effectively able to operate in those areas together with its existing service area. And I think perhaps more important, it is exactly the area where its patients are. Not just the patients of Mount Sinai and its network, but the lives, and I don't need to dehumanize people, but the lives that it will manage and manages under the state's reform efforts. They are throughout the 5 boroughs, so it's the same area overlap. I wasn't intending to speak to process, but let me make a couple quick comments. I do respect process significantly as an attorney, but I also think there's elasticity in the guidance and the rules that you have for your consideration. I think that a guideline that says you really have to work within what's been filed as part of an application makes sense. At the same time, the public hearing is established so you can ask questions. So what you elicited in terms of arguably somebody else would say additional information, was really responsive to the questions that the public hearing elicited from the hearing officer and the panel. And I think that means that's exactly what this hearing is for, not to just say exactly the same words, but to explain. I also think that there is a gap in time between the time of the application and the hearing, and it has to be that any new developments during that time frame are fair game for discussion if they speak to public need, just as you heard. So it can't be something that's a snapshot and forever a snapshot as the system evolves, as RFPs are responded to. Substantively, I respectfully submit that they've met the standard for public need, both from a common sense standpoint as well as within the context of reform and what is expected through care coordination and other aspects of population health. But I also say, as we've discussed at these hearings before and earlier, very much within the policy that REMSCO has embraced. I had not called it 0606 either. Actually, what it's called here is 93-10, which has been superseded by 0606, but the language is the same. And I do think that they have very much met the standard in there, which focuses on addressing an inadequate level of care that cannot be addressed through reconfiguration of existing resources. And they list a number of criteria, whether it's 0606 or REMSCO's embracing of it, that take into account not just quantitative factors, and the backdrop is increased call volume, increased response, and the evaporation of their partner from the system. So it's the quantitative is there, but very much the qualitative and the development and the evolution of the system in terms of care needs, existing service needs, existing service effectiveness, and services change over time. Reliability and response, you heard how they very much want to focus on the reliability and response, even though they're contracting perhaps in different boroughs and for different services. They cannot let happen again what did happen in this case. And then it also lists other locally defined factors, and I don't mean that that's some broad-based Wild West criteria, but you've really heard the experience that has taken place in the 5 boroughs and not wanting to have that occur again. I will make one more comment, and it is, this particular model is, I think, very much what the City of New York has encouraged. I don't speak for them. I'll say it again. I do not speak for the City of New York, but they have asked Greater New York on several occasions to set up meetings. I have participated in those meetings, and the City of New York similarly does not want to have what happened with TransCare happen again, and they're therefore very much encouraging the hospitals to be participating in 911 and delivering those services themselves. So I think you have an applicant who has very much met what the system is asking of them, what the definition of public need expects to be met, and then also what the city expects of them. Thank you.
Ms. Wolfer, thank you very much. I am told that due to his health, Mr. Dinnerstein is not going to be with us physically this evening, and he's with us in spirit. We're wishing him better health and peace. So these are the only people that I believe that have asked to speak officially. It is my unofficial policy. I'm more than happy. I see other people from the community. We have some stalwart union members still there, and we're glad for that. If anyone would like to speak on behalf or in opposition to the application, I would invite you to come up, and we'll be glad to hear you, and we thank you for your time. Would anyone like to join us? Miss, please come on up.
I was told I can't ask any questions as I do live in the community, but I am speaking here not as a carpenter, but as an EMT.
And if I could, if you could just, and I'm going to allow you to do this. I'm not told that you can or can't. I may be overextending, but I think that you made it through 3 hours of gripping testimony and comment tonight.
And it was at time.
And if you could just identify yourself, and we'd love to hear you.
Sure, my name is Hunter Nakai. I'm
Could you spell your last name, Ms. Nakai?
sure, and as Nancy, A-K-A-I. Your doctor, I can't remember his name, Dr. Gandhi.
Yes.
No, that's fine. That's, thank you, sorry. Your community paramedicine sounds fantastic, and I'm interested as an EMT and as a medic. But what I wanted to know, when, let's say you have, when your patient is speaking to you and you decide to dispatch an ambulance, we go by medical control. So would you be acting as medical control at that moment, or would you call down a medical control to dispatch an ambulance?
Great question. So generally speaking, in the programs we've had, it's the primary physician who knows the patient, who receives that call from the patient, and then they dispatch, and I act as medical director of offline medical control. Those physicians have gone through a certification process, so they don't have OLMC credentials, but they have a new level of certification that we created through the REMAC called telemedicine physician. And so they're limited to provide medical control for patients who they have established relationship with. And so it's that same physician who who requested the ambulance response, who then later receives the call back from the paramedic and is able to provide orders to the paramedic, and they do everything within the scope of practice of the provider.
Great, and let's say you're at one particular hospital and a patient calls this other gentleman, doctor, and he decides that, you know what, this patient also needs an ambulance. So do you communicate with each other? Like, how do you know that that you haven't like run out of ambulances because you've sent one to one place, there's 911 ambulances doing something else, and there's another ambulance like transporting? I'm just trying to figure out.
So you're saying the patient called the doctor asked for community paramedicine, and then while we're waiting for the community paramedicine response, the patient then called 911?
No, a different patient
Oh,
calls
second
a different
patient.
doctor. So I'm just trying to figure out
when
like,
we had
where the limit is.
when we had TransCare, the process was we would always call and get an ETA. If the ETA was unacceptable, then the physician would have to use whatever other resources existed, whether that be a non-911 transport response, they could transport the patient to an ED, or whether that be a referring to 911. So a second patient may or may not mean that there's no resource available. In fact, we ask them to always strive for 90% of the time having 2 units available during the previous contract.
And if I could just add, remember that this was a narrow scope right now. We're doing a pilot. That's certainly not, what we're looking for in the future. We're looking for expanding this so that multiple patients can be calling at the same time, and we can be using. Again, that's why we need to have all this diversity in how we approach this, right? Because that's going to be quite a task, right? To be able to kind of fill the needs for this larger population. That certainly, whether it's 4 ambulances or how many, however we do this, we're going to need more than just us.
And something else, when I worked in a nursing home, sometimes Hatzola would show up, before the ambulance would show up, you'd have someone from Hatzola show up, let's say in the car, they're just there, they're in the area, they're there sooner than the ambulance can show up. And I think there's a pilot program in Hoboken where they don't have enough paramedics or EMTs, where they have actually some of them on a bicycle to show up to a person before the ambulance shows up. Have you thought of, might that be something that you can look into, like send a paramedic or even a PA or something before, just to double check, because sometimes people, and I've seen them in a nursing home where they're actually not as, they panic, so they're not as sick as they think they are. So maybe before dispatching an ambulance that they may not need, maybe they just need a paramedic that can assist them with their medication and maybe just a kind word to calm them down and to bring down their blood pressure so they don't actually need an ambulance.
So I think that's a great suggestion. I think that I'm also kind of getting that suggestion from members of the panel. I think that if you consider that there's already a certain number of ambulances available doing a number of roles, and in the absence program they're going to get an ambulance to respond to them, then maybe it's that same ambulance that just has a few more capabilities that can now coordinate care in the field, and somehow that might be actually be as or more efficient than, in addition to existing ambulances, having an extra single paramedic doing something. That being said, I don't want to say that there's no definitive way this has to work. In fact, it could probably work on a number of different ways, and I think that's what's kind of exciting about the future of EMS, and I think that Mount Sinai is looking to sort of be a participant in sort of exploring those options, and I don't want to say yes or no that would be how it is, but I think that's definitely a possibility.
Thank you so much, I appreciate it. Thanks.
Thank you, Mr. Kai. Anyone else would like to come up and say? Dr. Ramsey, would you like to say?
We have a brief exit comment.
Can everybody hear me? I will not regurgitate what everybody else has said, and I will not summarize every testimony that's been provided, because I...
No, we can't hear you.
You can't hear me now?
No, just hold it close to your mouth.
Okay,
Yeah.
now you can hear me.
Yes.
I can hear myself. So I just want to stress one point, which I know you as the hearing officer has wrestled with, and that's the difference between public need and Mount Sinai. And I think that we have tried to demonstrate that there are many needs out there that the public has that we're trying to satisfy. And when the witnesses here who are from Mount Sinai speak about Mount Sinai, they're talking about an entity that's a not-for-profit corporation, a tax-exempt entity with a charitable mission. The whole reason for being is to meet public need, because that's what it is created to do. It is not a profit-making enterprise. The other thing is, or one other thing is, that the state has mandated all of these programs that Mount Sinai has described in detail here, paramedicine and other things like that, are the result of state initiatives telling Mount Sinai and others that they have to provide services in a different way. So while Mount Sinai has embraced these directives and certainly gone forward in many great directions that will benefit the public, they're doing it because the state, which is the public, is telling them that they must. And that's also true about consolidation of services, which Susan Waltman testified to with great eloquence. The state is pushing enterprises, hospital enterprises, to come together into larger units. And they're encouraging in other ways, like ACOs and preferred providers, through other programs with a lot of money behind them, to bring many providers into one organization for most purposes. And a lot of what Mount Sinai is doing is responding to those state demands and trying to meet the public need that those demands create, because now we have a big institution covering a lot of ground, and we have new programs creating great need on top of the underlying charitable mission which Mount Sinai has had for 150 years or more to promote. So I think it's not like there's such a great distinction between Mount Sinai need and public need. There's an overlap, and there may be some things that are specifically enhancing Mount Sinai's interests, but for the most part, what Mount Sinai is trying to achieve is the meeting of need, the meeting of public need, and fulfilling a public purpose in that way. So I understand the dilemma or the eternal discussion about what that distinction means, but I don't think it's a distinction with a difference. I think it's words that are really describing different sides of the same coin. And with that, I leave you to the record that's been made.
Ms. Miller, thank you very, very much. I am going to step a little bit further than perhaps I thought I could / than I thought I could. Ms. Waltman indicated, or she suggested that I could, in my role, try to seek more information to amplify what has been presented, to amplify the existing application. And I opened the door a couple of times, and I didn't mean, I hope I wasn't too brusque when I made my suggestion, and there's no data that would show that you couldn't provide an ambulance with a certain amount of time, and we've had these experiences. We've had situations where your RFP seems to have kind of been overlapping with the submission of the certificate of need application, and I am going to welcome provisionally information that you could submit on those issues within a reasonable period of time. I don't know what that reasonable period of time is. I assume I'm a reason.
In order for us to maintain appropriate timeframe to be brought to the council, we must make this a very short window.
So
Certainly have the ability to request additional information. We just need to have a definitive time span.
Okay.
So this way it does not delay the voting any other processes that are in the
and I don't want to delay the ambulance committee. I'm not sure when its next meeting. I'm not sure that that's necessarily relevant. But if I were to suggest to the applicant that I would look at, subject to objection, to any is Ms. Tadeo, is she still here? If she left, well, I'll give her an opportunity. She's not here. I'll give her an opportunity to say I am, or give her an opportunity to say I'm not on. The ability to include it. I'll give her an opportunity for notice on that. But I would welcome looking at information that would amplify the existing application. I'm not looking for new evidence, but since I opened the door on the scenario and we talk back and forth, I'd welcome that information and the information on the RFP. And we can make a date certain of.
We're going to give you a date certain before the end of the evening.
I can give you a date certain of 7 days from today.
We're going to give you a date certain, yeah, in 1 minute. We're just looking at this calendar.
Okay, no problem.
While you're finding the date, I think we need a clear idea of what it is that you want.
So,
We don't
well,
want to be in a position where
well,
we're supplementing the whole application.
Let me be clear. So if you're saying that we Mount Sinai West need to have this because we found that our ambulances aren't, our contract ambulances, they can't get there within X number of minutes, hours. Therefore, we need to develop other means of sending our specialized population health. I'm losing it now. Community population health, paramedics.
Okay, so it's, as I understand it, it's ETAs and delays in that area for.
Your client is saying that you need it because you can't get ambulances fast enough, and I'm saying I don't have any data. And Ms. Tadeo said, I think she would have agreed with me. I think she may have, in fact, that there wasn't a whole lot of data. Well, you got a chance if there is any data and anything within your system to show it to us.
And that's specific to transfers.
That's where this came out.
Well, within that framework.
Okay.
Because you're not talking about emergency, you're not talking about emergency response, that's within regular.
Delayed
So if you're saying,
response
we need to do this population health, paramedicine, we're gonna need to go and do this and whatever. Maybe you have information, doctor, from your your pilot program with TransCare, and you said, this is why we did it, maybe there's rationale that you had to have for your board of directors or your board of whoever's. If you have data like that, again, I'm not looking for names, you want to redact whatever you need to redact, but the more original documentation that you have, as opposed to just a summary, oh, we needed this and we needed that. That could be enlightening.
Okay, so just to be clear, the community paramedicine was a pilot, and we have that data that was quoted tonight. We can show you that, but that's not where the discussion about delays was involved.
Okay.
It was involved in the transfer service,
Okay.
and so we can provide you with that data.
Okay. Sorry for conflating.
No problem.
Okay, Marie.
In order for this to work on our timeline, we need this by Friday the 17th, so it gives you 3 days. Sorry, 10.
10 days.
Friday.
Friday.
Does that work?
Friday the 10th, this is Friday.
It's 3 days.
3 days.
Okay.
Is there anything else
Does
that
that
you
mean,
want?
when does that mean that you need my report?
By the 17th.
Trust me, my job is harder.
Is there anything that you want to see?
Peace on earth? Copy of the RFP, I've had stereo from the committee. If you can, if you have it, if it's available, I think the committee, would you like to see it when you vote?
Yeah, I think,
Sure, I'm not gonna, if the committee would like it, it amplifies it, and maybe increases your chances of getting it through the ambulance committee, then hey, maybe in your interest.
It's not an issue, I don't think.
So,
Have a
the other
We
thing
have to-
is,
we have to read
when I
that.
provide a
In the
copy-
microphone, Mr. Miller.
When I provide a copy to you on behalf of Mount Sinai, I'll send a copy to Karen as well. So she has.
Sure, you submit it directly to REMSCO, and as a courtesy, so there were, I know, I saw some correspondence about delays and whatever.
Should I leave it to do you want to take care of it?
Send it
Send it
to
directly
Marie
to
and Nancy.
Marie, and we'll make
And
sure
you'll
it
make
gets
sure it gets to
distributed
wherever you want it to
to
send it.
everyone.
Okay.
Okay, and if it's done electronically, it happens, I mean, Marie and Nancy are amazing, and they get things back out very, very, very quickly. So that's probably the most efficient way.
Electronic means, we have to have that.
All right, anything further from anybody? Anybody wish to share? Okay, I thank everyone. I appreciate the information that I've learned tonight. Again, I leave with questions and concerns and things that I'd like to learn separate and apart from the rules here. Please trust me that when I say I'm going to be fair and impartial. And I'm meeting, as Mr. Millick has referred, I need to stay within the boundaries of this. And as Ms. Walton said, there is some locally defined factors, but I will get to you the report by the 17th, and I trust that you get the information back to us as soon as possible. Okay.
On behalf of Mount Sinai, we really thank you and the public for being here tonight, and I certainly appreciate all the time that was spent, and I really appreciate my colleagues as well. But thank you very much for listening to our summary of our application and
Dr.
explanation.
Ramsey, thank you, thanks you, Doc, for all your colleagues and the people who've come here tonight. Thanks everyone, get home safe. And I'll declare the hearing is closed.